Chapter 8, Therapeutic Relationships. So the concept of the nurse-patient relationship, okay, this is important, and we may hit some more of these before we do next week's lecture. Since we only have 2 chapters, we may go through this a little bit again. This is the basis of all psychiatric nursing treatment approaches. So the nurse-patient relationship is the basis of all of this. The therapeutic relationship creates a space where caring and healing can occur. It is the nurse that establishes with the patient that they are safe, they will be confidential, they will be reliable, and they will be consistent. This is also a relationship with clear boundaries, as we will be learning a lot more about over the next few weeks. So your therapeutic use of self as a nurse. You use your personality consciously and in full awareness. All the time when you're working with these patients, you do show them your personality. It is that we attempt to establish relatedness. So it is okay to relate to your patient and know that, yes, I'm a human being, and understand that also. The therapeutic relationship is one of the greatest predictors of a positive patient outcome. So talk therapy, this actually changes brain chemistry according to your book. And medication and psychotherapy is the best treatment for the majority of psychiatric problems. We really don't have a whole lot outside of that, other than there are some procedures and things that can be done, but they don't have a ton of success the way that they do with medications and therapy. So the goals and functions is to facilitate communication of distressing thoughts and feelings, assist patient with problem solving, help patient examine self-defeating behaviors and test alternatives, and promote self-care and independence. And a lot of times you're almost a sounding board when you're turning things back to them and talking to them and letting them know, like kind of just rewording what they've said so they can think about it and see what it is exactly that is stressing them out or causing them bad feelings or performing these self-defeating behaviors. We can actually help them in looking for the alternative and talking with them about what it is that's truly going on that's causing all of these things. So social relationships differ from the therapeutic relationship. So what a social relationship is this is a relationship between two people that is initiated for the purpose of friendship, socializing, some kind of enjoyment, or accomplishment of a task. So when you're working in your groups as students, you are in a social relationship. Mutual needs are met. So you are working on your portion, that person's working on their portion, and you're both learning things at the same time. Communication is to give advice, give or ask for help. So it goes back and forth, back and forth. I talk about me, you talk about you. I talk about me, you talk about you. And then social relationships, as I've already said, are different from the therapeutic relationship. So here's the difference. The therapeutic relationship is about the patient. It is not getting our needs of the relationship met at all. This is only for the patient. So the patient needs have to be identified and explored. You need to remember that the patient wants to be heard. The focus is the patient's ideas, experiences, and feelings. Sometimes students have a hard time with this because we just talked about in the previous slide about relatedness. And yes, you want to relate, but it's not about you. And if it starts to turn about you and things that you're doing and things in your life, and you're starting to use them as a sounding board, then the boundaries are not balanced, and you need to take a look at that because clear boundaries are established in a therapeutic relationship. Problem-solving approaches are taken. The nurse's goal is to help the patient implement the solutions to their problems. We also help them with new coping skills that they're developing, and we help them with different behavioral changes that we would like to encourage them to take. So, necessary behaviors for us nurses working with these patients. We need to be accountable, responsible for our own conduct and the consequences that happen because of that conduct. The focus is on the patient's needs. We need to advocate for what the patient needs, not what we want or need. Clinical competence, the knowledge of evidence-based practice. Delaying judgment. And you see I wrote big letters here. Yes, yes, yes. Always delay your judgment in these patients that you're going to be working with, because You don't know what it's like to live in their shoes. And even if you've experienced something similar, you still don't know what it's like for them. So always try to delay that judgment. You'll be a much more effective nurse if you can delay your judgment. And obviously we do supervision with these patients. So establishing boundaries, know your boundaries. Physical boundaries is your general environment. Your contract is the agreement between the nurse and the patient, and then personal space. And then I went ahead and put up here your average comfort levels in personal space distance in the U.S. You can go ahead and take a look at this and be familiar with what it is for the different things. But as you can see, for people that are strangers, a little more than 4 feet, which if you measure that out, I mean, it's a little bit of a distance between two people. And that's when you're first meeting your patient, you're a stranger. So that's where it starts. And then it changes as the relationship is established. So blurring of boundaries. The struggle is real. You will all know what I mean by the end of this clinical rotation. Boundaries are necessary to protect the patient. When the relationship slips into the social context is when the major blurring is starting. You'll be able to see when it happens, when you feel like you're being more of a social friend than you are being the nurse. And when the nurse's needs are met at the expense of the patient's needs. And this happens, and we're definitely going to talk about this in class because this is a very important thing that we need to discuss face to face. So blurring of roles. These are going to be important words that you're going to want to know. Transference is the patient unconsciously and inappropriately displaces onto nurse feelings and behaviors related to significant figures in patient's past. So for instance, I had a patient who was very irritated with me for a number of days, and 2 of the 3 days I worked with her, she was accusing me of not giving her medication the days before, to the point where it got to I had to actually have another nurse stand there with me while I would give her the medication. Because the next day, every day, she would tell the next nurse, the night nurse, that I didn't give her her meds, and then the next day she would accuse me of not giving her medications. So on her last day of treatment, she came to me and she said, she gave me an apology, made amends with me, and told me, "You just remind me so much of my estranged sister, and I know you weren't not giving me my meds, and I was just taking that out on you." So that is a perfect example of transference, where the patient was treating me in a way that she wants to treat her estranged sister. So transference is intensified in relationships of authority. So physicians, nurses, social workers. There's positive and negative transference. Typically, positive transference does not need to be addressed. But the transference with the negative feelings include hostility, jealousy, competitiveness, but then there's the love. And like I said, typically those ones don't have to be addressed, but there are times that they do too. So your countertransference is when the nurse displaces feelings related to people and the nurses pass on to the patient. The patient's transference to the nurse often results in a countertransference. Strong or negative reactions towards patients often signals countertransference. So an example of this is being overly emotional about a patient who possibly tried to commit suicide that you had worked with for some time, especially when this is something that those in the mental health field deal with all the time. Or if a patient, I think there's an example in your book, a patient's doing really well and the nurse is overly happy. It's okay to be happy, but why am I so much more happy for this patient? A common sign of countertransference in nurses is the over-identification with the patient. So I can identify with this patient so much more. So you have to watch out for power struggles. And the question for you is, are you a rescuer? Why do you want to rescue this particular patient versus all the other patients? This is a major boundary and a very difficult thing. It may not sound like it is, but it really is. So values, beliefs, and self-awareness. The nurse's values and beliefs. It reflects our own culture and subculture, what we were raised to believe. It's derived from ranges of choices we've made, what we've chosen to believe, and chosen from a variety of influence and role models, things that have influenced our decision this far. So with a patient, you do not get into these struggles, you agree to disagree. And sometimes you make that agreement in your own mind and you don't say it out loud. Patient behaviors and nurse reactions. Secret keeping. The nurse cannot promise this. No matter what the patient says, you cannot promise that you will totally keep a secret because we share with other members of the team. Asking personal questions, you're going to want to redirect this back to the patient. They want to ask you questions. Try to ask them very similar questions to go back because we need to keep the focus on them. Interruptions. If another patient comes and interrupts you as you're working with one patient, you set boundaries with the interrupting patient and say, I will be with you as soon as I am done with my current patient, because you have to maintain the contract you already made with the patient that you're already with. Gifts. Money or expensive gifts are always graciously refused. If it's given at the end of treatment after healthy relationship is developed, graciously accept. And examples would be a card or a small little token of some kind from like a gift shop, if there's a gift shop like there's a gift shop at Brighton, things like that. But we never take expensive things, we never take money, and if it seems like it's in a healthy context, you go ahead and accept that. And that can be different with different facilities, but at Brighton it was okay. So I got these different pictures. Flowers and cards would be okay to accept. Money, a necklace, or a promise of services would not be okay to accept. So Peplow's model, the orientation phase, this is where rapport and trust is established, the parameters are defined, confidentiality and contract is discussed, and this is the responsibility of both parties, like I was saying today in class, that we even build their care plans with them. And then the orientation phase is when the termination phase is introduced. So if you see something like that, that's when it is first discussed. Termination begins at orientation. So the working phase is maintain the relationship, gather and share information, issues are explored and resolved, facilitate behavioral change, and the patients may experience intense emotions and defense mechanisms during this working phase. This is where almost everything is happening throughout their stay or treatment or whatever is happening within your relationship with them is during the working phase. Almost everything gets worked out there. So then your termination phase is summarizing the goals, evaluating outcomes, discussing the new strategies, exchanging memories. The patient can learn from the nurse that it's acceptable to feel sadness or loss, because patients often feel very sad about leaving us after we've been with them. Termination is a learning experience. It's sad for students as well. And demonstration of care. So make sure you read page 142. I'm looking to see actually what I put that there for. Just reread page 142 about maintaining contact after discharge is not acceptable and it is in opposition to the goals of the therapeutic relationship, and then what hinders and what helps the nurse-patient relationship. And you do want to ask the patient, how do they feel about being discharged? Factors that can help the nurse-patient relationship is consistency, the continuity of care, being honest and consistent, your pacing with the patient. Make sure you go at the patient's pace, not yours. Listening, this is the most important skill. You listen to them. This is not about you. And initial impressions, pay attention to yourself. Where can we obtain initial impressions? And the big question there is in report, because if the prior nurse had a bad experience with this patient, we can make an initial impression of them before we ever meet them, and that's totally unfair to the patient. So continuing, promoting patient comfort and balancing control. It is a balancing act, not too strict, not too lenient. Patient factors include the patient's or the trust in the nurse, the patient's trust in the nurse, and active participation. The nurse cannot work harder than the patient, and you'll hear that all the time in Brighton. We cannot work harder on their recovery than they do. Genuineness, truly listen and use communication spontaneously. Empathy, not sympathy. And with empathy, we understand. With sympathy, we feel. Sympathy is a feeling of pity and commiseration. Positive regard implies respect. Attitudes, willingness to work with patient and actions. And I believe this is the last slide. And you can read it because I don't have time. That's it.